Good morning. My name is Judy Liu, Senior Director of Innovation for the Gerontological Society of America. Welcome to the webinar, Medicare Annual Wellness Visit, as Springboard to Detection of Cognitive Impairment, Diagnosis, and Post-Diagnosis Support. This program is developed by the Gerontological Society of America and supported by Eli Lilly and Company. The webinar is being recorded and it will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. One moment as we just check one technical issue, if you will. If you could bear with us one moment. All right, thanks for bearing with us for one moment. I think hopefully we've resolved a minor technical issue. Let me proceed. A question and answer session will immediately follow the live presentation. We will be accepting questions through the questions feature accessible on the right-hand side of your screen. Our presenters for today's program are Katie Maslow and Dr. Sherry Ling. Katie Maslow is a longtime GSA member and scholar in residence at the Institute of Medicine, National Academy of Sciences. Dr. Sherry Ling is Deputy Chief Medical Officer at the Centers for Medicare and Medicaid Services, Center for Clinical Standards and Quality. Thank you both for being a part of this important program today. So that we can all know just a little bit about who's in the audience this morning, you will see a poll displayed on your screen. You can click your response and then click the submit button to lock it in. We will be quiet for just a moment while you read through the choices and make your selection. And I see people clicking in now, so that's great. Just give a few more seconds since people still seem to be submitting their answers. And I don't want to leave anyone out of an opportunity to post. So here we go. I think I will close now so we can see who is in the audience. So it looks like we've got 31% from academia, 14% from industry, 12% from government, 17% from medical practice, and 26% from other. Okay. So without further delay, I'll pass the microphone over to Katie.
Thank you, Judy, and thank you to all of you for calling in. This issue of detection and diagnosis of dementia is important. Many of us have been working on this for a long time on this issue, and I'm sure many of you have also been working on and thinking about it for many years. So during the webinar, Sherry Ling and I are going to give you some background on the work group progress and process, its recommendations. Sherry is going to talk about the CMS perspective on this issue, and then I'm going to talk again talking about detection, diagnosis, and documentation, and their relationship to access to care and services. So before we start, just to let you know, Rick Fortinsky, who many of you may know from the University of Connecticut Center on Aging, led this project and was supposed to be giving this first section, which I'm going to give. So we miss him. He had a family emergency. And so I will try to fill in for him as best I can. So this GSA work group was formed in the fall of 2013 with support from Eli Lilly Company. The work group included 5 federal agency staff members. We were very lucky to have Sherry as part of the group and representatives from the CDC, HRSA, the National Institute on Aging, and AHRQ. We had several other committee members and some important ex officio members, including representatives from the Alzheimer's Association. We met 3 times in person and numerous times by phone and by email. Just to give you a little bit of background on this project, as you may probably know, many studies over years, 15 or 20 years, have shown that there are large gaps in diagnosis of dementia, large gaps in the detection of cognitive impairment, which is a necessary precursor to diagnosis. Increased detection of cognitive impairment is essential for earlier diagnosis of Alzheimer's disease and related dementia, and also earlier diagnosis leads to more timely linkage of older adults and their families with community-based services and supports. We'll talk more about that later. As some of you may know, there was a recent systematic review which looked at detection and diagnosis of dementia in medical records and found that only about half of people with diagnosable dementia had anything in their medical record that suggested that they had the condition. So that's the problem that we were dealing with. There are significant disparities in this area. In particular, African American and Hispanic older people often experience longer delays than non-Hispanic whites between awareness, their awareness or awareness of family members of their cognitive impairment, and then diagnosis, detection in the healthcare setting, and diagnosis. This problem of insufficient detection and diagnosis of dementia is going to increase in numbers, at least, as our population gets older and the older population itself ages, so that more people are in the age group that's at very, very high risk of Alzheimer's and other dementias. So the charge for the GSA Workgroup was to summarize the efforts that are currently underway by government organizations and private sector organizations to identify evidence-based assessment tools that could be used in detecting cognitive. Our work was based in the Medicare Annual Wellness Visit with the idea that that visit, now part of Medicare, provided a wonderful springboard for increasing detection and diagnosis of dementia and for the use of evidence-based tools to help primary care providers detect possible dementia. In this context, we decided early on that the primary care providers we were talking about were not only physicians, but also physician assistants, nurse practitioners. CMS has a definition, actually it's part of the law and the regulations, for other health educators and others who are able to provide the care that's allowed in the Medicare Annual Wellness Visit and bill for it. Sherry will talk much more about that and knows much more than I do about it. So as you probably know, the Medicare Annual Wellness Visit was authorized, mandated as part of the Patient Protection and Affordable Care Act, the Health Reform Act that has received so much attention. As a result of that act, all Medicare beneficiaries are entitled to an annual wellness visit where, and this is in the law, detection of any cognitive impairment is a mandated component. As I said, we viewed this as an opportunity to increase the use of evidence-based cognitive assessment tools in order to improve detection of cognitive impairment. The law itself does not say that the primary care provider must use any tool to detect cognitive impairment. It doesn't specify which tool. It doesn't require that the primary care provider record the process that was followed, any tool that might have been used, or the result of the assessment. So our focus was the possibility of increasing the use of evidence-based assessment tools in order to promote better detection, more complete detection of cognitive impairment in the primary care setting. So first we looked at what others had done. I don't know how many of you are familiar with these previous efforts. Many of us were not as we started, and really they are pretty amazing. In response to the legislation, CMS has done a great deal of work to implement the annual wellness visit. The National Institute of Aging was very helpful, worked closely with CMS, did an extensive review of assessment instruments to detect cognitive impairment with using criteria that they thought or they decided were appropriate for the primary care setting. These tools, they believe, needed to take 5 minutes to administer. They needed to assess not only memory, but also at least one other cognitive domain. They needed to be validated in the U.S., in community or primary care settings, and they needed to be free of charge with easy access to primary care providers. So NIA conducted this extensive review of available instruments, found 138 instruments. The results of their work are available on the NIA website, and it was very carefully done. In addition, the Alzheimer's Association convened a work group to provide guidance for primary care providers on assessment tools and a process for assessment during the Medicare Annual Wellness Visit. The Alzheimer's Association did not do as extensive a review of available instruments as the National Institute on Aging, but did review what the members of that work group were familiar with and spent a lot of time focused on the process of care, the process of detection and diagnosis, what should follow, and some very valuable principles of care. There's a great article about this that the lead author is Cindy Cordell from the Alzheimer's Association, and both the NIA material and the Alzheimer's Association article were very valuable to our GSA work group, and I recommend them highly to you. So based on that review of the material that I just mentioned, plus knowledge of the members of the GSA work group, and especially our 5 members from federal agencies, all of which are involved in implementation of the annual wellness visit. We developed a diagram to show the movement of Medicare beneficiaries through the Medicare Annual Wellness Visit from referral to post-diagnostic care and use of community resources. We developed preliminary recommended actions related to the steps in the flow diagram, which you'll see in a minute. And we discussed trying to organize and convene a national Stakeholder Summit this year to help implement the recommended actions in primary care settings. We also have a report which you'll receive after this webinar. So here is our flow diagram, and it shows our recommendations in 4 steps. This looks simpler than it is. It took a great deal of work. I'll get back to that in a second, just to go through these steps with you. So assuming that we're focused on an annual wellness visit, that is that particular kind of visit, the PCP, the primary care provider, would learn or ask about memory or cognitive complaints or observe clinical signs and symptoms in that visit. Those are the recommended ways in the current regulations for detecting cognitive impairment. So you see those in step 1. The work group recognized that an older person can visit a primary care provider at any time during the year. It doesn't have to be during an annual wellness visit, and these same steps can occur in those other kinds of visits. As a second step, if the primary care provider recognizes problems, possible symptoms of dementia in the older person, or hears from a family member or another informant that there are concerns in the family, or hears concerns from the person about their memory, then the work group recommends the use of an evidence-based assessment tool to detect cognitive impairment. So you'll see the some possible tools in the next slide. As a third step, and this is very important, sometimes people, primary care providers, and many other people, and a lot of people in the public, believe that all you need is one of these short tests, brief assessment tests, and then you know that the person has dementia. That's not true. The work group feels very strongly that that is just a first step, and that actually it's our second step in our flow diagram. So that it's very important then to conduct a full evaluation, a diagnostic evaluation. That is, first to rule out reversible causes of the cognitive impairment that's been found, and then to go on to figure out if the person does have dementia, what causes that dementia. So then the fourth step, once a diagnosis is made, the primary care provider decides whether to refer the person to a specialist, but importantly, it's necessary to develop a care plan, to begin to work with the family, and to be sure that the person is referred to valuable community services. You can see the desired outcomes here. We can talk more about that if you want to later, and we'll end up talking about some of those outcomes. So what we did, we concluded that it's really not possible at this point to say, and I guess it might never be possible to say exactly which assessment instrument is good, is best for the annual wellness visit or any primary care provider setting or practice. So what you see here is the assessment instruments that were selected by the National Institute on Aging Working Group and the instruments that were selected by the Alzheimer's Association Working Group. And if you can see on your slides, 2 of the assessment instruments were recommended by both. And so, again, these are just recommendations. The 88, which you may be familiar with, is a, for this recommendation purposes, it is the family caregiver instrument that's being recommended. So it's given to an informant. It's 8 questions, has been validated in numerous studies. And then the mini-cog, what's represented by both. But again, you can see many, many choices. So here are our ideas for the Stakeholder Summit. We're hoping to continue this discussion about detection. The again, some of this seems simple. I was startled during the discussion, the meetings that we had, and again, as I was preparing to do the webinar, by how complex these issues are. Not as a start, not with the global or umbrella kind of commitment to detection and diagnosis and good care, but with all of the complicated and complex issues that arise. Sherry is going to talk now from the CMS perspective about this, but I think it's important to keep in mind that it's not just, the issues aren't only on the provider side, the primary care provider side. There are many issues, many barriers that are also from the perspective of the person with dementia, thinking in terms of stigma and fear associated with a diagnosis, and with many families. So in our Stakeholder Summit, we're thinking of looking at this issue again from those 3 general perspectives. So Sherry Ling, as Judy said at the beginning, Sherry is the Deputy Chief Medical Officer at the Centers for Medicare and Medicaid Services, and she's been a wonderful participant in the GSA Workgroup.
Thank you, Katie, and thank you to GSA for hosting this webinar. I must say it has been a distinct honor, pleasure, and also purely enjoyable having conversations about this important topic. And one of the unique aspects of the conversation during this work group has been that multiple perspectives are represented. The people with dementia, their family members, care providers, and those who are on the sender side of a consultative request, and also those on a receiver side of that. So health systems perspectives and also industry. So it has been a delightful and energizing conversation. And we actually began with some questions to run on that I will just share with you so that you know and have the opportunity to think about. These are not easy questions to answer. As Katie alluded to, this is a process where we are collectively creating an opportunity and finding the best means to implement that opportunity to detect that there is a problem with cognition that translates then into an appropriate diagnosis, but ultimately that a care plan then is created, crafted, and implemented in a way that really improves outcomes. So what outcomes really matter most to people who have dementia, be it Alzheimer's disease or others, their families, and the like, so we could all align according to those outcomes. And if we could go to the next slide. And as Katie accurately mentioned, this conversation was framed in the context of the annual wellness visit. But importantly, to remember that this is a springboard for this conversation. This was an opportunity that was created, that requirement to assess cognition, however one would implement that, be it with the use of a detection tool or by history or by family history and risk assessment, is really subject to personal choices as a provider. And the reason that it is intended to create this opportunity but do so in the most flexible manner is that the context of when an assessment is done, we cannot assume that a person with cognitive impairment will enter at the early stage when detection using specific tools, brief tools, would be most valuable. It is entirely possible that a person with cognitive impairment can present for their initial welcome to Medicare exam and subsequent annual wellness visits with more significant impairment than would be appropriate to assess with a what we would call a detection tool or a screening tool. It is also necessary that we keep in mind that the annual wellness visit is in and of itself multidimensional. It is intended to assess one's health status, not just cognition, but on many other levels, and create an opportunity to actually develop a personal prevention plan that includes cognitive management of cognitive issues. The other reason that flexibility is required is that it is entirely possible that people who have cognitive impairment and dementia will manifest in other settings when they're first admitted to the hospital, or when they are seeking an evaluation for a surgical procedure. So that is not an annual wellness visit opportunity, and yet we do not want this signal to be lost, that at any point someone touches upon the health system is an opportunity to ask the question, are you okay? So this is really a springboard, and the final point of complexity or how complicated this is that people are complex, and that with age comes multiple chronic illnesses, one of which is dementia. So, the process of detection translating into diagnosis and a care plan of management has to take into account the context that is represented by a person with dementia, or within people with dementia who may have likely other comorbidities. So flexibility is required. Next slide, please. So with that in mind, it really is a question then of what outcomes, what health outcomes really matter. And certainly being able to think and function, those are outcomes that we want our beneficiaries to be able to be able to achieve and engage in their lives as they would want to do. So we try to focus, and we focus the conversation of how do we actually take this opportunity for assessment and translate it into diagnosis and then the care plan so that we can achieve the best outcomes with this opportunity. So what we would consider an undesirable outcome would be if one is found to have an impairment. Okay, there's an impairment, but then what? To not have that addressed in the context of a care plan or appropriate diagnosis, and importantly, as Katie mentioned, excluding potentially reversible causes of cognitive impairment, that would not be a desirable outcome. So our work just begins with the initial detection. Next slide. And what we discuss as a opportunity further is presented by what is happening out there in our health systems, that we have remarkable technologic tools and opportunities. So thought we would approach this from the technical perspective as well. We know that well over 200,000 professionals are already receiving electronic health record meaningful use incentive payments. This also is increasing in the hospital space. So being that this is a technical tool that we believe can be meaningfully used to try to address cognitive evaluation in the context of this emerging and evolving technical opportunity. Next slide, please. So as such, as Katie mentioned, there are the phases of this assessment, and admittedly it is illustrated in a linear fashion, but certainly can be entered into its stage 2 instead of stage 1, so it may be that cognitive issues are so apparent that you go straight to diagnosis. So this is depicted in a linear fashion just for the sake of conversation. And as Katie mentioned, the detection permits use of, but does not require use of, brief assessment tools. And absolutely right, those tools were evaluated, many tools were evaluated using the criteria Katie mentioned, but had to include being able to be implemented and used in a brief period of time and having been validated in a primary care or a care management type of setting. So, and a manifestation of what this might look like as a technical solution is to create the data elements that would be standardized, that permit and encourage the uptake of detection. So that would need to be standardized across different instruments. So what that would look like also will take some work. Next slide, please. And then, of course, diagnosis. So the diagnosis, the process of diagnosis could be completed by primary care providers or dementia care specialists, or a combination of all of the above, but should include evaluation and exclusion of potentially reversible causes using the appropriate laboratory testing, history, etc. But this too can be operationalized in the context of health information technology and could also be guided through clinical decision support. And so there is an opportunity there as well. Next slide, please. And of course, care planning. Now, importantly, translating detection into diagnosis and to care planning, that is the trifecta. That is the completion, and care planning that results in a discussion of what outcomes matter, how do we use this information to really benefit people and families, is really the nature of the conversation that this is intended to spark. There's no one right recipe for a care plan or a conversation or shared decision making based on the findings, but the important flexibility that this imparts is that, you know, the opportunity exists. Let's seize it and do it in a way that really syncs well and is well aligned with who the person is who's coming in for the evaluation and what the care needs are and what resources there are that the individual has, but also that their family, however that is defined, and social network has at their disposal to engage with the healthcare system. Next slide, please. And we have also had to wrestle with the conversations where the interpretation of what is sufficient evidence to support screening. It is true that screening asymptomatic populations is not, it was determined to be not supported by the evidence. And so this is not intended to walk away with the notion of the annual wellness visit is discordant with the USPSTF statements. That is not the intent at all. This is an opportunity that we try to be really true to the evidence and yet create the service in a way that is most flexible and best meets the needs of the population. But this is all in conversation. What this webinar and other presentations, including that at the GSA, really are intended to do is start the conversations at a community level, at a community of providers, within the community of providers, and for us to start asking additional questions. So, you know, how best to communicate in a timely manner with providers and beneficiaries and their families about the information as it evolves. This is work in progress, but as we approach the development of a learning health system, this is exactly the nature of the conversation that has to occur. So with that, I will stop and turn it back to Katie.
Thank you, Sherry. So you will have an opportunity, or I guess ongoing, you have the opportunity to submit questions, and Sherry is a wonderful expert on existing policies, so if you have questions about that, those questions can be answered later, and with the email process later on, even after the webinar. So please let us know if you have those questions. And also I recommend again to you this report and recommendation. Hope that you'll read that when you get it. You'll have a much clearer understanding, I think, than of some of the things that Sherry and I have been talking about. I want to talk just briefly now about why this is so important. So Sherry and I have both emphasized how complex it is. It looks simple as you start out. Why don't we just do this? Use these instruments and detect cognitive impairment and go on with diagnosis and better care after that. It's more complex than that. But I think that it's important to realize that this is really critical for the care of people with Alzheimer's and other dementias. I think that's why so many of us are trying so hard to figure out how it should be done best. So the bottom line, at least as far as I'm concerned, is that detection and diagnosis, and I would add documentation there, of cognitive impairment and dementia are essential for appropriate medical care for older people, people with any cognitive impairment, and for appropriate home and community-based services, and then ultimately for desirable health outcomes, quality of life outcomes, and so on. So why is this so important? And as I'm talking, I think that you can look at this from a positive point of view. If we can detect and diagnose, document, and then do the care plan that Sherry's talking about, we can improve care. If we don't do those things, there are a lot of risks. There are risks of poor care and poor outcomes. So, as you know, it can be very difficult in a primary care setting to understand a patient's status and problem when the patient is cognitively impaired, can't remember any history, his or her own medical history, may not be able to report symptoms accurately. So that it's important to be aware when that is the case with one's patient, and to be aware so that one can then enlist a family member or another informant to assist. Sherry mentioned that older people with medical conditions are often complex. People with dementia, most people with dementia have multiple other serious medical conditions. If their cognitive impairment isn't recognized and their dementia is diagnosed, it's very difficult to imagine how care can proceed in an effective way for those other medical conditions. The person may not be able to understand what a primary care provider is telling them to do about their other medical condition, may not be able to remember or follow through, and the physician or other primary care provider may not be aware of that. That's a problem. If the cognitive impairment and possible dementia aren't recognized, the person, the family, the provider have no reason to consider Alzheimer's medications, which, as all of you probably know, don't cure the underlying condition but are helpful for some people. And it's important that if the underlying condition is a condition that causes dementia, it's important to avoid treating other conditions, treating the condition as if it were depression or another psychiatric condition. It's also important that primary care providers be aware of cognitive impairment and dementia because of the value of talking to the person and the family about possible safety issues. So driving, falls, wandering, getting lost, guns in the home. This is one that is particularly frightening to me. In terms of the medical care setting, and here I think that the documentation that I wanted to add is particularly important. If a person's primary care physician or other primary care provider may be aware of their cognitive impairment but have not really diagnosed it or then documented the diagnosis, if that person goes into the emergency department staff is unlikely to be aware of the condition and then has to proceed with potentially a lot of unnecessary tests and treatments in order to cope with a situation where they don't have appropriate history or understanding. The same in the hospital. A person with dementia goes into the hospital without a documented diagnosis, and the staff, all kinds of hospital staff members, are unaware of maybe unaware of their cognitive impairment, and so not able to institute practices that could avoid problems. Wandering, elopement, very dangerous in the hospital setting with a person with dementia. As you can see on the slide, other issues, loss of functional abilities, a person who is very confused and doesn't eat or have enough fluid intake in the hospital. Staff in hospitals are perfectly capable of addressing these problems, but will only do so if they're aware of the situation. So I think that it's important that we move ahead with finding ways, as Sherry said, to effectively detect, diagnose, document, and then produce a care plan for these conditions. There are many guidelines, many of you may be aware of these, to help various kinds of healthcare providers deliver appropriate care for people with dementia. Those guidelines are not going to be used if the dementia is not detected. So the goal really is to not make dementia the center of medical care, but rather to have the primary care provider and others be able to manage the person's care overall with awareness of how that person's care should be managed, considering that they have cognitive impairment and dementia. In terms of home and community-based services, it's true that we don't have enough of these services. Many communities lack important services. On the other hand, older people are very, very unlikely to be referred for services that could help them when their cognitive impairment is not detected and diagnosed. So just as noted on the slide, there are 50 or 60 now treatments and care practices. These are non-drug treatments and care practices that have been shown in randomized trials to benefit people with dementia. There are additional care practices and treatments that are being developed all the time, and without awareness of these of the person's condition, these valuable treatments are not going to be used. So just, I'm sure all of you are aware of these. These are some of the kinds of services that the person with dementia or the family member could be referred to that have been shown to be very helpful for people with dementia and their families. So adult day programs, nursing homes that have appropriate care for people with cognitive impairment and dementia, and similarly assisted living facilities. And just lastly, we placed emphasis in our work group on earlier detection and diagnosis. And as Jerry said, some people the diagnosis is not made until very, very late in the course of a dementing illness. But recently there's been the development of some very exciting programs. We're not at the place of randomized trials yet, but programs that are for the person with early cognitive impairment dementia. These individuals can feel very isolated and alone, and these activities that you can see here, the Memory Club, Meet Up and Mentor, it's a program that's been developed in Minnesota. Physical activity, exercise, social activity, recreation. Many of these programs have we have early evidence that they delay progression. They don't change the underlying disease, but they delay progression of cognitive impairment, the worsening of the condition, and they also improve quality of life greatly, and that is a wonderful blessing for the family also. So Sherry said our work begins with detection. I think that that's right. And without this detection, which has been so difficult a knot for us to untie and to get ready, we aren't going to have diagnosis. We're not going to have the documentation, the care planning, and these benefits. So hopefully GSA's involvement is wonderful here, and it hopefully will help to make these issues better known and to increase understanding about the importance of detection and the various ways that can be used to help primary care providers detect cognitive impairment. Judy.
Thank you. So on behalf of the Gerontological Society of America, Katie, Dr. Lang, and I, we thank you very much for your participation today. And we thank you to Eli Lilly and Company for providing the support for this program. Just a reminder that we are recording the session, and we will send you an access link by email once the recording is available. And you will be able to download a copy of the presentation slides and recommendations report from the website listed at the bottom of the screen. Before we move to the question and answer portion of this program, please know a webinar survey will automatically launch after the webinar. In an effort for continual improvement, we would like to hear your thoughts, so please provide feedback by clicking the survey link at the end of the webinar. Now moving along to our question and answer session, another friendly reminder that you can type and send questions using the feature in the dashboard accessible on the right-hand side of your screen. We will not be using the raised hand feature today, so if you have a question, please be sure to use that panel. And Katie and Dr. Lang will do our best to address as many questions as possible, time permitting, during the last part of this webinar. All right. Would you like to start with the one that we have in front of you?
Certainly. Yeah, so this is Sherry Ling. So a question came in for some of the administrative, to understand the administrative details of who actually is permitted to perform the annual wellness visit and who also can receive the annual wellness visit. So so let me start with the latter. Of course, this is who can receive the annual wellness visit are all Medicare beneficiaries. And because it is the annual wellness visit, it is intended to be within 12-month intervals. So at least that 11 months have passed since the initial Welcome to Medicare exam or the last annual wellness visit was performed. And who can actually perform the visit, and I will, this is one of the most frequently asked questions that we receive, and that would be, as Katie said, a health professional, meaning physician, qualified non-physician practitioners, that is a physician assistant, nurse practitioner, or certified clinical nurse specialist, or medical professional including health educators, registered dietitians, nutrition professionals, or other licensed practitioner, or a team of such medical professionals who are working under the direct supervision of a physician. Those individuals are permitted to perform the annual wellness visit. There is some subtlety between, or some distinction between which annual wellness visit codes to use, whether it's the first annual wellness visit or the subsequent one. All of that information is actually contained in a annual wellness visit chart that is accessible through the Medicare Learning Network. It is accurate and up to date. We are in the process of modifying the elements slightly, given that the physician fee schedule rule has just been published, et cetera. But all that information is accessible if you go to the Medicare website, or can also Google search Medicare Learning Network. Importantly, the details are not only in the PDF, but at the end of the PDF. So this walks you through all of the elements of the annual wellness visit and the codes used, and also in the resource section contains some of these responses to frequently asked questions, as well as links to the claims processing manual and other educational resources that are very practical and to the point of answering how do we actually do this, and what documentation and what are the requirements to submit on a claim. One other part of this question is what is not an annual wellness visit. And so although the cognitive evaluation and assessment, be it by way of interview or by way of a test, one could think of this as part of a physical, as one could think of the wellness visit as a physical, but it is not. This is not the same as a beneficiary's yearly physical. So as you all know, this is not a routine physical checkup that some senior and older adult patients or Medicare beneficiaries can receive every year or two from their physician or another qualified non-physician practitioner. So as you know, Medicare does not cover routine physical exams, so this is intentionally distinct from a routine physical exam. And any, if problems are detected in the context of a wellness visit, that should be documented. As Katie mentioned, please do document. And also a care plan should be crafted, one that the person actually understands and can follow through on. And if additional testing or evaluations are required to further investigate cognitive limitations or impairment or difficulties, that actually would be a separate, could be coded as a separate visit, evaluation and management visit. So there are some nuances to exactly how you put the pieces together, but all that information is accessible. And again, if you search for Medicare Learning Network, that we have updated documents there and should have an update on this topic sometime in February, so next month. Hopefully that helps answers some of these questions, and I'll conclude my response.
Thank you so much, Dr. Ling, and we'll be sure to send out the exact link to everyone following the program. It's a fantastic site.
So this is Katie, I just wanted to address a couple of the questions. We're going to run out of time, but in terms of Peter Whitehouse's questions and observations, this is some of the complexity that Sherry and I were talking about. His questions are very right and very important. So we're looking with detection of cognitive impairment for impairment that would affect the individual's health care and need for community resources, I think in particular. So we're not just looking at looking to find cognitive impairment, we're looking for a reason. But again, Peter's comments here are very insightful. I see a couple that look like they're easy to answer. One is that the 8 assessment tools that Sherry mentioned are in your PowerPoint. They are the ones that are listed as CMS NIA recommended in one of the earlier slides. Sherry, do you see?
Yeah, just to mention, as Katie built on Peter Whitehouse's questions, these are really important questions in that how do we as a health system implement these opportunities in a way that does improve outcomes? So certainly, you know, as I mentioned earlier, overdiagnosis, we need to be cautious about overdiagnosis, and so, you know, scoring badly on one of the brief tests is not sufficient for a diagnosis. And likewise, you know, there are promising emerging technologies that we hope will help ascertain specific disease processes early and point out the opportunity for intervention, a definitive therapeutics, but importantly, as stated in the National Alzheimer's Plan, it is about effective management in the meantime. I mean, and Katie, those interventions that you spoke of, including effective use of existing resources and development of new resources to help people meaningfully engage and maintain their activities and quality of life, that's all part of effective management. So I think, you know, this is a very exciting field, and delighted that you all have joined us today for this conversation.
Indeed. Thank you very much again for this hour together. I'm very sorry to say that our time is up, but are there any last thoughts or comments?
I just wanted to say, this is Katie, that there is a major role for social workers here, of course, in awareness of signs and symptoms of cognitive impairment in the people that they work with. I think this is very important. And likewise for families and family caregivers, the annual wellness visit, actually, if the caregiver is Medicare eligible, then that caregiver would receive the detection of cognitive impairment procedure. But I think that you can tell that when we include the ADA, which is an instrument for asking the family caregiver about the person's cognition, that the caregivers are central here.
Thank you. Great hour again together. So thank you to everyone for participating. This